She's the head of the Department of Gynecology at Fernandez Hospital, Hyderabad. Over to you.
Thank you very much. Good morning again. So this time I'll be talking about perimenopausal bleeding issues and solutions, some of which may overlap with my previous speaker. So how do we define perimenopause? According to WHO, it is that period immediately prior to menopause, that is when the endocrinological, the biological and clinical features of menopause begin and ends at 1 year after menopause. It is that period of time during which the physiological changes mark progression towards the final menstrual period. Different arbitrary limits have been quoted, somewhere between 40 to 54, 42 to 52, and so on, or from 4 years before to the 12 months of final menstrual period. So different definitions exist, and it begins with the onset of menstrual irregularity. That is a starting point. It continues till a woman reaches menopause or 1 year after, and it can last for a variable amount of time, the median of which is around 4 years. And changing hormone levels manifest in different symptoms, which can present with complex management situations to us clinicians. So we should know what is this time period, arbitrarily somewhere between 45 to 52. So it has an early stage and a late stage. The early stage is by the odd skipped periods. The second stage is by greater irregularity, with periods coming anywhere between 2 months to 12 months. 12 or more months of amenorrhea defines the final menstrual period, after which menses are very unlikely. So the STRAW definition, STRAW is Staging of Reproductive Aging workshop, which took place in 2001. So they term early menopausal transition as persistent 7 days or more difference in cycle length in consecutive cycles. That is the early menopausal transition with mild irregularity. Then comes the late transition, where the amenorrhea lasts anywhere between 60 days to 12 months. Post-menopause is obviously very clear, 1 year after menopause. In this phase, various hormones will be decreasing. We only know about FSH and estradiol, but they're also looking at inhibin as a marker, AMH as a marker. So now they don't recommend us doing FSH to decide is the woman in perimenopause. So different symptoms start in this phase of life: vasomotor, vaginal, sexual changes, sleep, mood changes, and bleeding issues. More than 90% will present to us gynecologists for advice during this phase for one symptom or another. So today we're going to focus on abnormal bleeding. This is a frequent symptom in this phase. There is alteration in the duration, frequency, or amount, which is considered excessive and that can negatively affect the quality of life as well as psychological well-being of the woman. Definitions are very simple, but the practical use is that abnormal menstrual bleeding during the transition or within the first year of menopause. This is better defined this way for us to be clinically useful, except for cyclical bleeding when the woman is on hormones. So you cannot count that as perimenopausal AUB. So 1/3 of our gynec patients in our OPD belong to this group of AUB in the perimenopause. It's not only a common reason for OP visits, also for emergency admissions, for hysterectomies, and often mismanaged too. More than 90% experience at least one episode of AUB, and 78% at least 3 episodes of AUB during this transition. What is important is for us to identify the ones out of this big percentage who actually need intervention. We have discarded the previous nomenclature. We're all using this terminology now by FIGO. A thorough evaluation is important for 2 reasons in this age group. One, you want to exclude serious pathology like carcinomas or atypical hyperplasias. 2, you want to identify the cause so that the right treatment can be given to that patient, which sometimes can be just wait and watch. So the etiological classification of FIGO in 2011, revised in 18, forms the basis of our evaluation. In other words, we're looking for structured causes and non-structural causes for the AUB in this phase of life. A thorough history is always very important. Patient-centered questions. They don't know they have to volunteer this information to us. So you will have to ask for any bleeding disorders, any information on other medications they're on, all of these can contribute to the symptoms. Unless you ask, they won't tell us they're on aspirin or clopidogrel or warfarin, and you pose for surgery and then you cut a sorry figure. Screen for coagulation disorders. I'm sure Sunil will remember a case we did long ago. An unmarried girl with torsion came in as emergency, rolling in the bed with pain, and we took her up as emergency, and then we just simply couldn't control the bleeding. And later on, a surgeon, an oncosurgeon, all of us came, and we did a laparotomy, never this happened. And she was just diffusely oozing. Finally, I took my gloves out and went and asked her, is there anything you're not telling us? Then coolly they tell she has a bleeding disorder, and they told them that at 11 years it will sort itself, so that's why we didn't tell you. So after evaluation, she was found to have factor V deficiency. So when to screen for coagulation disorders? The incidence of von Willebrand's is up to 13% of women with HMD. 20% have a coagulation disorder. Others can have hemophilia or platelet function disorders. So you can't test all women for all these tests. So you need a screening tool. So also drugs and systemic illnesses can also cause coagulation disturbance. So keep that in mind. So this is a screening tool we apply to our patients, particularly all posted for surgery. Do they have heavy menstrual bleeding since menarche? Any one of the following: PPH or surgery-related bleeding, or bleeding with dental work. 2 or more of the following conditions: bruising once or twice a month, epistaxis, frequent gum bleeding, family history, all of these. So women who have these are then worked up by a hematologist. Very, very important, so you don't have accidents on table. Examine the patient. So the basics are the same: history, evaluation, examination for various endocrine dysfunctions, for PCOS, and don't forget to examine speculum and vaginal examination. We had umpteen cases referred from outside for abnormal bleeding, not responding to medical treatment, only for us to put a speculum and find a big polyp over there. So don't forget cut corners. Routine lab tests, as we all do, are important, and focus your hematological tests for screen positive patients. These hormones are not routinely required, but they're used as surrogate markers for menopause, FSH, AMH. But if the AMH is more than 200 nanograms per ml, they say that the menopause is unlikely in the next 4 to 5 years. Okay? But these are only in research setting. They're not practically useful, so don't order these tests in this stage. There are also other markers. Androgen deficiency is also a feature of menopause transition, but you don't need to do these tests. I'm only making you aware that these tests are done by people and not at all required. What is required is a pap smear, and imaging, simple ultrasound, transvaginal and abdominal, and selectively you do MRI, and then hysteroscopy if you find structural causes, and endometrial biopsy as warranted. In women more than 40 with thick endometrium need a biopsy. We are talking about perimenopause. So we all do Whipple sampling. It samples 4%, but if you actually under ultrasound guidance or not, you try to get tissue from all 4 walls, the yield is usually good and we don't miss pathology. So look at these structural causes by a thorough ultrasound by an experienced person. Use this classification for fibroids. You can use, each woman can have more than one cause. It can be P1, A1, it can be A1, M1. So use this chart and tick what the patient has got. The common imaging features, we all should be aware of looking at ultrasound reports and the images. Now 3D has come in and we are rarely missing structural regions. Each condition has a different appearance, so be well versed with them. Ovulatory disorders in PCO, the scan, uterus will be normal, but the endometrium will be thick. In intermenstrual spotting, look for local causes as well as any subtle signs of endometritis like fluid in the cavity. Iatrogenic, is there a copper T missing in the cavity? AVM comes in not classified category, which you can pick it up on ultrasound. So the treatment will be structured to the cause found, tailored to the cause found. Polyps, you need to do surgery. Adenomyosis can be treated with progesterones. Myomas, depending on their grade, some may need surgery, some may need follow-up. Malignancy, obviously sampling will tell you, and then you have to proceed with surgery. In nulliparous women with atypical hyperplasia, you could try with progesterones, get 2 negative biopsies before you actually give them pregnancy. And after pregnancy, we don't lose the patient. You may even have to resort to a hysterectomy. So Marina has come, is a very helpful tool in this age group to tide over the period till they reach menopause. The local brands are, I'm not sure if Emily is available right now, Aloira in Maharashtra. In US you have Skyla, different names. You know, this is called the mini Marina, which works for 3 years. You have Liletta, you have Kylina, so many different trade names are there. Jadus is the version in the UK with 3-year Marina. So the cause depends on the age of the patient. In the 40 and above perimenopausal group, it could be anovulatory, it could be hyperplasia, it could be malignancy, it could be fibroids, it could be polyps. So let's look at 4 to 5 cases. I have actually 10, depends, I have 6 minutes. Let's see how many we can get to. So this is a 52-year-old lady. Her periods are irregular. Since October 2020, she presented to us in January 21, that is 3 months later. She says that since the period in December, she's been bleeding on and off, okay? She's a known hypertensive. Any guesses? Everybody thought it is perimenopausal AUB. She came with a scan report outside. There's a mass lesion with cystic spaces. Again, we thought it's a polyp, okay? Anybody would do any other test? Yeah, exactly. So we did a scan. There's a snowstorm appearing mass over there, suggestive of molar. Then we went and did a beta HCG, which was more than 4 lakhs. Then obviously we advised suction evacuation with follow-up and chemotherapy if required, if the trend is not dropping. The couple asked for hysterectomy. Okay, we said even though we do hysterectomy, you still need beta HCG follow-up. They went home to decide, only to come 4 to 5 days later with shortness of breath. And thyrotoxicosis related high output cardiac failure is what she ended up with, and she was shifted to multi-speciality upon request. We followed the case there, and the gynecologist did a suction evacuation and then did a vaginal hysterectomy. I'm not sure why she chose that, but all ended well. The pathology confirmed complete mole, and at 2 months later her HCG became negative. The second case is also pretty much similar. 42-year-old who's not planning pregnancy came to us with irregular bleeding, previously regular cycles. So we thought, you know, some hormone imbalance, anovulatory dysfunction, only for us to do a scan to find a ectopic pregnancy. And the UPT was positive. What I'm trying to say here is pregnancy is a possibility in perimenopause. Although 84% of them end up in miscarriages, the incidence of ectopic increases in this age group. Keep that in mind. Up to 12 months after final menstrual period, excluding pregnancy is a mandatory part of evaluation of AUB workup. This is another case, Mrs. SR, who came to us this year, September, with heavy periods of 1.5 years, leading to an anemia of 5 grams. Okay, she is known to have cervical polyp and a thick ET on outside scan, so she was advised surgery, came to our hospital. So we did examine, we did confirm cervical polyp. PAP we did, and it was negative, only to rule out abnormal PAP, because we're doing a procedure we want to combine if required, if PAP is abnormal. So when we did a scan, it was not just thick ET. There were 2 submucous fibroids, one grade 1 and another one grade 0 with an ET of 12.5 along with the cervical polyp. So if you now, these are the images. I don't, for paucity of time, I will just directly go. This is the cervical polyp. So these are the submucous fibroids, one behind the other. Can you see 2 big balls? So we counseled her, we improved her anemia and then took this case. We removed both the fibroids and the cervical polyp. She's doing very well now. She's hassle-free and everted a hysterectomy. She was actually advised hysterectomy outside. So I'll skip that. This is another case, 43-year-old, again with frequent heavy cycles. Examination was normal, PAP was negative. A polyp was suspected on scan, so we advised hysteroscopy, EB polypectomy, And this is what we find, lot of thickened endometrium, hyperplastic endometrium, and a polyp on the posterior wall. That's the one. Okay, so we cleaned the uterus, and it came as hyperplasia without atypia and a benign polyp, and then she's now doing well and managing. So what I'm trying to say is tailor your treatment to the cause found on your investigations. This is another lady, 54-year-old, with prolonged bleeding since 1 month, but on detailed history, she has been having irregular bleeding since more than a year. So to cut a long story short, they did a scan. There's a lobulated mass filling this uterine cavity, as you can see there, with color flow. And when we put this one turned out to be malignant. You can suspect it when you see it. It's irregular, it's vascular, okay? So she then went on to have hysterectomy with pelvic lymph node dissection and is currently doing well. I'll skip these routine cases and I will go on to this. This is another case who was advised hysterectomy outside. She is in her late 40s, and when you put the scope, this one. When you put the speculum, this is what you find in the OP. For this, they advise hysterectomy. They have not examined her. The actual cavity is normal. So we just removed, and the patient wouldn't believe us, and she would tell, are you sure I don't need a hysterectomy? You know, the impact of the first advice on a patient's mind is very hard to remove. And it is our responsibility to keep on reassuring her. So with this, I'll stop the cases, have an algorithmic approach in dealing with perimenopausal bleeding issues, go systematically so you don't miss out any cause, keep palm coin in your mind, and these are the steps. Describe the cycle, confirm the source, do a pregnancy test, is ovulation occurring, do routine lab tests, good ultrasound, endometrial biopsy, you will not miss anything. These worksheets, palm coin worksheets, are very useful. You can keep in your files so you don't miss out any cause. So I conclude by saying causes vary by age. Have a systematic approach, clinical picture the cause, choose the right treatment. If you're putting them on HRT, thorough counseling extremely important. Remarkable inconsistency in management has now been reduced by using this palm coin. Thank you very much.
Thank you, madam, for that wonderful talk. Thank you for highlighting the point that history taking and clinical examination, including per speculum and bimanual pelvic examination, is very important before resorting to other investigative modalities. Thank you.
There are no questions.
Any questions from the audience?